Definition of anemia and classification of anemia. As clinicians, we define the anemia into three major categories. Hypoproliferative anemia, in which there is a production defect, the marrow does not produce enough RBCs. Ineffective erythropoiesis, that means red blood cells, they don't mature properly. So the erythropoiesis is there, but it is not maturing properly, which are eventually destroyed. Or there may be loss of blood in the periphery, which is blood loss or hemolysis. These can also lead to anemia. So there can be decreased red cell survival leading to anemia. So these are the three basic mechanisms which produce anemia. Now if we go by the algorithm that how to go around with a case of anemia with all the armamentarium we have just seen. So when we have anemia, we do the simple reticulocyte count, CBC, these are done. So the CBC confirms that it is anemia, and the reticulocyte count further gives us two divisions. If the reticulocyte index, kindly note the word used is index over here, if it is less than 2.5 or if it is more than 2.5. If it is more than 2.5, it is thought that the marrow is responding adequately. If it is less than 2.5, so it gives something to do with the, then the marrow, the red blood cell morphology is seen. If it is index is less than 2.5, then the red blood cell morphology is seen carefully. So if we have we will have two things. Either we will have normocytic, normochromic anemia, or we will have a microcytic or macrocytic. Either the size will be more or less. If it is normocytic and the retic is also less than 2.5, then the conditions are that it is a hypoproliferative anemia. Maybe that there is some problem with the marrow. Either it is infiltrated by something like some other cells or maybe some infection, or there is damage to the marrow, or there may be some other reasons for the hypoplasia. This is one thing. Second thing is it could be because of iron deficiency. We all know that iron deficiency anemia causes microcytic hypochromic anemia, but in the initial stages, after all, it is a hypoproliferative anemia because the substrate is not there, iron is not there, so it may lead to this picture initially, that is the normocytic, normochromic and hypoproliferative anemia. Then decreased stimulation of the marrow. This occurs in renal disease when erythropoietin is not synthesized, or there is some metabolism or rather inflammatory defects. So anemia of chronic disease, these also come here. Second is when there is some particular RBC shape or rather size, if it is microcytic or macrocytic. Now if it is microcytic, then we think in terms of iron deficiency, we think in terms of some thalassemias or sideroblastic anemia. So there is small, the cell will be small. If a nuclear problem is there, nuclear defects are there like folate deficiency, vitamin B12 deficiency, then it will be a macrocytic anemia. Now on the other hand, if the index was more than 2.5, then we think in terms of hemolysis or we think in terms of hemorrhage. So here there can be blood loss, which can kick the bone marrow to produce more RBCs. Still the anemia may be there, but the reticulocyte production index or reticulocyte index will increase. Similarly, membrane. Now, if we have intravascular hemolysis, that may occur in G6PD deficiency, it is very dangerous. Or we may have metabolic defects, which may be because of pyruvate kinase deficiency, or there may be some hemoglobinopathy. We know it could be because of sickle cell anemia or thalassemia, or there may be immune destruction, or there may be fragmentation hemolysis. By fragmentation hemolysis, we mean the schistocytes are present. And schistocytes, as we have already seen, are present in TTP, that is thrombotic thrombocytopenic purpura, whose, that is hemolytic uremic syndrome, and DXA. These are the three main conditions. So this is the algorithm we follow clinically to decide what is the type of anemia that we are dealing with. Thank you.